You are live.
Thank you so much. So good afternoon. It is wonderful to see you. Welcome to the Maryland Health Insurance Coverage Protection Commission. This is our last meeting for the year. Senator Feldman and I co-chair this commission, but we couldn't do it without the help of Jennifer and Lisa, who are amazing. We have a great team. I want to thank all the commissioners for the work you have put throughout the years for this commission. You should be very proud, and you hear at the end of the work that this commission has been instrumental in getting done with the help of our team. So today we have a great agenda, so we're going to get started right away. And we have a lot of different panels. The first panel is the State of Maryland analysis of potential Medicaid buy-in options. As you know, this has been a request. I know that I invited Delegate Ariana Kelly. This was her bill, and I know that we said that this commission will look at it. And we're going to have Julie Pepper, principal of Wakely Consulting Group, LLC, Michael Cohen, senior consultant at Wakely, and Lydia Tallman, who's a senior consulting actuary at Wakely, and they will present on the potential Medicaid buy-in options. And then after that, we'll have an update on the Maryland Easy Enrollment Program from our wonderful partner in crime, Michelle Everly, who we love to work with. And the rest of the agenda will be handled by my wonderful colleague, Senator Feldman. So let's get started with the first panel, and welcome. Thank you for your time. Julie Pepper.
Okay. Thank you very much, and thanks for having us here today.
It's a pleasure to have you. Thank you.
Yeah, so I'm going to run through the presentation, and I'm going to invite Michael and Lydia to hop in if I forget anything or if I say anything wrong. And I believe we have around 20 minutes. Is that correct?
More or less, yes.
Okay. So we do have a lot of material to cover, and I believe you all have the slide deck. So I'm going to go through it fairly quickly, just to make sure we can kind of cover all of the information. But please do not hesitate, to ask any questions along the way if I'm kind of jumping over some key concepts, et cetera, that you would like to discuss. So I'm just going to dive in, but feel free to stop me along the way as needed.
And if I may, Ms. Pepper, we also have our wonderful Chair of Finance, Senator Kelly, with us. So we have members of the House and the Senate as well.
Okay, great. Thank you.
Delegate Collins.
Okay. So yeah, so the agenda today, again, we'll just do a really brief background, but then we're going to kind of focus on the key results of the three different buy-in options that we analyzed. So we'll kind of keep, again, in the beginning, I'm just going to go over it really briefly to kind of set the foundation and the stage, and then we can kind of talk through a high-level comparison of the three options that we looked at and analyzed, and then we'll dig into a little bit deeper into each of those options, and then talk at the end about additional considerations that may not necessarily be related to the numbers, but provide some caveats and then some additional considerations outside of just the numbers. So going to the next slide, it kind of highlights the three different Medicaid buy-in options that we looked at. So, you can see that the main goal of all three options, we have the targeted Medicaid buy-in, which I'll define those a little bit later in more detail, the qualified health public plan option, and then the Medicaid buy-in for all. All three options analyzed really have the goal of reducing the uninsured rate and improving affordability. So I think that was kind of the genesis of kind of the bill, is to really try to, Maryland has a very low uninsured rate, but can it go even lower? And can you improve affordability for a portion of your population as well? So on the next slide, it shows the current distribution of Marylanders for the under 65 population. So you can see that, right now it's about a 5% uninsured rate, which is, very favorable compared to the national average. And about 2/3 of the current under 65 population in Maryland are enrolled in employer groups, and about 7% in the individual market. So that's kind of just to set kind of the stage in terms when we talk about who we're kind of benefiting in this population, or in these different options. So the next slide starts walking through kind of some really high level kind of what are each of these options really doing. And again, as I mentioned, we're going to go into a little bit more detail into each of these options and kind of what we modeled in the results. But a few things to point out from this slide is that the targeted buy-in and the Medicaid for All are separate programs from the current individual ACA market. So separate risk pools have separate premiums, a lot more flexibility when you're outside of kind of the ACA market. The QHP option is really providing another plan per se that's within the current individual ACA market, would be part of the individual ACA market risk pool, et cetera. So a key distinction for the QH option plan. The targeted population also varies for these three different options. So we'll go into a little bit more detail in terms of what those are. And there is some overlap, and they kind of all touch on the same themes. But again, it's around making premiums affordable and for certain segments of the population. And then one key assumption that's really important throughout all of these is that we are assuming that the current provider network would be the Medicaid provider network and at Medicaid payment rates. So Medicaid payment rates we're currently assuming to be about 12% below the current commercial rates, and that's kind of across inpatient, outpatient, professional. Medicaid rates tend to be higher or closer to commercial rates in Maryland than in other states. So you're not going to see that a huge difference in premiums, where you might in other states where there's a much larger differential between commercial and Medicaid, but it is still a difference. And so we'll talk a little bit later about it's a pretty broad assumption to assume that the provider network would remain stable, and that would be a viable solution, that there'd be kind of no changes to the network and the provider payment rates, but we'll talk about that a little bit later. So just wanted to make sure that everyone knew that that was kind of a foundational assumption. And then the last key difference to talk here is about the benefit to consumers. So how are we reducing premiums for each of these? And so, we're trying to reduce premiums and make premiums more affordable to the different populations that we're trying to address here. The targeted buy-in really does that a little bit with lowering premiums, but also there are premium subsidies that are provided to certain targeted populations. The QHP option, it's really just about reducing premiums that will hopefully help the kind of the unsubsidized population. And then the Medicaid for buy-in, we actually modeled a few different scenarios. So one of them is just, okay, we're going to have lower premiums, but we're expecting people to still kind of contribute to premiums at the current level, to actually premiums being free and there being no charge to enroll. So kind of have a pretty wide spectrum there, but how we're kind of assuming that premiums will become more affordable kind of varies by the different options as well. On the next slide, we talk about really at a high level what the results are to the various options. So you can see an extremely wide range of what the impact is to the uninsured. So you go everywhere from the QHP option, it's actually possible that the uninsured would go up slightly by $3,600 to the Medicaid for All virtually, if the program is free, you would assume almost all of the uninsured would then be covered under that program. So a pretty wide range of impacts to the uninsured, and then the targeted buy-in is somewhere in the middle. But obviously you can see it on the state costs as well. We're talking about billions of dollars for Medicaid for All, really negligible costs to the state. We're not including operational costs in our analysis. And then some modest costs for the targeted buy-in. The impact to the uninsured is obviously correlated to the state costs that we're talking about as well. All right. If there are no questions, I'm going to start going into a little bit deeper dive into each of the different options. But if there's any foundational questions,
we will wait until the end and we'll ask questions. Is that
okay? Perfect.
Thank you.
Thank you for letting me know. Okay, so for the targeted buy-in population, again, the key here is that it really is targeting certain populations. And these populations are either going to hopefully have lower premiums, or they're going to get subsidies that are similar to what the ACA gets, not ARP, but under the ACA program. And that's the family glitch and the undocumented. So these two populations currently are not eligible for premium subsidies in the ACA market. So the intent would be that these people could actually get premium subsidies and would be more likely to get coverage. There are some of these people that are currently enrolled either through employer coverage or in the individual market, but there is a vast majority that are either paying very high premiums in order to get that coverage or that are remaining uninsured because of the lack of subsidies. And then there is the smaller targeted population of those just ineligible for subsidies that might either be covered in the current individual market or uninsured. And to the extent that premiums can be a little bit lower because of the Medicaid provider payment rates in this program, might migrate over to this public option or the buy-in and get lower premiums. Cost sharing for this plan, we assumed would be similar to kind of what was popular in the current ACA market, which is either a bronze, which is a 60% actual value, or a 73% actual value, which actually is a little bit above the silver level. So we kind of look at those two different levels. I want to be clear, these, the bronze is typically more considered kind of catastrophic coverage. So we're not saying this is going to be an extremely rich plan, and there might still be, barriers to access at a 60% level. They'll still have access to preventive care and hopefully some lower cost, co-pays for office visits, et cetera. At the 73% actual value, probably a lot more co-pay type services will be available, but it's still not, the average of kind of what the employer market has today. So, but again, trying to kind of balance what's kind of popular in the individual market, given premiums, and also trying to balance the cost to the state. And then finally, we'll get into a lot more detail on this, but obviously the reinsurance program in the state of Maryland is very important. Has been very impactful to the premiums and the affordability of coverage in the state of Maryland. So how that gets impacted for this buy-in population is very important. And does it have an impact on the current reinsurance program in the individual ACA market? So we'll talk about the three different scenarios we considered with that and the impact on each of the programs. So the next slide shows kind of the overall enrollment estimates we have for the targeted buy-in population. So you can see that again, it varies based on our different assumptions, the level of cost sharing and the level of premium reduction, et cetera. But you can see that the family glitch is the predominant, portion of members who would be enrolling this. And a lot of them are coming from employer-sponsored insurance, but likely their premiums will be significantly lower because the ACA-like subsidies would reduce premiums more so than any kind of employer contribution. And then we do have some, again, family glitch people who have probably enrolled in the individual market that we're expecting would migrate to this plan, and then some family glitch that are currently uninsured that would migrate as well. And then in the undocumented, the vast majority that would migrate over are currently uninsured, and then there's a small portion that would that we believe that are probably enrolled off exchange, since the undocumented can't currently enroll on exchange. That might migrate over because of lower premiums and get subsidies. And then again, even though we're not expecting in some situations that the uninsured or those above 400% FPL, they're mostly going to be driven. Again, if they're above 400%, they're not going to be getting subsidies. So it really depends on how much lower the premiums will be in this buy-in program in terms of how many of those members migrate over to this program. On the next slide, you can see the state costs that are associated with each of those estimates. Again, we've kind of got the low and high enrollment estimates, and we have the low and high premium costs, or the cost to the state. So you can see, obviously, it correlates with, the family glitch members are driving a lot of the costs because they're also driving a lot of the enrollment into the program. So there's a correlation mostly. And then the citizens making above 400% FPL, because they're not getting subsidies, there's really no state cost associated with them. It's really where the subsidies are happening. And then because we did model different reinsurance scenarios, which we'll get into, there's a pretty wide range of what reinsurance costs could be as well. So you can see a pretty big difference in terms of what the state costs would be in terms of their decisions around what benefit levels to cover and how to kind of approach the reinsurance program as well. So the next slide then gets into what we would what we actually modeled around the reinsurance program. So there are three different types of programs that we modeled. The first that would be for the reinsurance program, that the buy-in program, the buy-in option would actually be included in the reinsurance program. But in doing so, we're saying wouldn't increase state funds. It would just be spread across both the current ACA market and this new buy-in option. So what that would do is say, okay, the same number of state and federal pass-through dollars have to cover a wider number of people. And what that does is it then reduces the effectiveness of the program. So the percent of premiums or the impact of premiums decreases then. So again, it's no change to state dollars, but it does reduce the effectiveness of the program. The second option was to include the targeted buy-in program and say, the states, we don't want to impact the effectiveness of the program. So we're going to make the effectiveness be the same in the buy-in option as we are in the current individual ACA market. So that actually is the one that has the highest state dollars to it, because we're saying we are going to offer reinsurance into the buy-in option similar to what's in the ACA market. And the final one is to exclude the targeted buy-in option from the reinsurance program altogether, which obviously reduces the effectiveness of the buy-in option because your premiums are going to be a lot higher than the current ACA individual market because there'd be no reinsurance, where there's a very sizable reduction in premium in the individual market due to reinsurance. But one thing I want to mention for this is that for the subsidized members, it doesn't really matter what happens with reinsurance in terms of what they pay for premiums, because their premiums are going to be maximized based on kind of what the ACA says the maximum premium would be. It just matters, is the state subsidizing them through reinsurance or through subsidies, or a combination of the two. The reinsurance program mostly really impacts the unsubsidized in terms of what their premiums will be, because they would benefit from a reinsurance program, but they're not going to benefit from a subsidy eligible program. So again, the population that gets benefited from the buy-in option depends on what happens with reinsurance for that program as well. So I'm going to move on. I think I'm close to already using up my 20 minutes, so I'm going to try and go through the next few a little bit faster here. So the next one is the QHP option. And so this one I think is a little bit more straightforward, where we're really just talking about offering another option on the individual market exchange that uses the Medicaid provider network and Medicaid payment rates. Again, I said we assume kind of a 12% reduction or lower provider payments, but admin costs were assumed to change or maybe modestly, and the pharmacy costs are not assumed to change. So overall, it really ends up only being about a 6% reduction in premiums as a result of that. So again, there's no additional subsidies. Undocumented can't enroll on exchange. The family glitch isn't impacted necessarily here. So this is really targeting the uninsured in hopes that it's a little bit lower premium, and also the individual market unsubsidized, making their current coverage a little bit more affordable. So we modeled the silver and gold option for this. So again, a little bit richer than what we did for the targeted buy-in, and reinsurance was just assumed to kind of be absorbed in this population, since it's in the individual market. So the next slide, again, I probably should mention for the first two options, we kind of looked at a kind of the initial year. There's always kind of a ramp up to any kind of program. So impacts could get higher in future years, but we're kind of looking at the initial first year of the program, at least for the first two buy-in options. So keys here are that because the premium impact is small, the impact is also small to overall enrollment as well. And subsidized members might actually be adversely impacted because as premiums decrease, it actually decreases their subsidies. So they may actually lose purchasing powers if they want to buy a different plan. So depending on the interaction with, uninsured taking up and subsidized members potentially dropping, we're looking at on average kind of a net neutral for this option, but with the option that it could be an increase or it could be a slight decrease. And then generally for this program, we're not assuming any state costs. There would be operational costs. And to the extent enrollment did increase, there could be some additional reinsurance costs. But this is really one that's it's intended to kind of provide a lower cost option. So no explicit subsidies, et cetera. Okay. And then the final option that we looked at was the Medicaid Buyin for all. So this obviously is the most ambitious of the three options and also going to be the most costly. But a few high level kind of just assumptions is that we despite the fact that this is kind of focused on the under 65 population, we're assuming Medicare would stay where it is. We did ignore the Medicaid population for our modeling because we assumed the state costs would kind of stay the same and that program could kind of, at least in theory, operate as is. So we kind of focused on the the commercial market and the uninsured markets in terms of what the cost to the state would be for those programs. For premiums, we modeled anything from kind of the state kind of what are the total costs, but then okay, if the state was going to get contributions from consumers, we just assumed it would kind of look similar to what was being paid today. So if employer contributions are happening and if employee contributions are happening, employees would kind of can still pay in the same amount. Similar on the ACA side, they pay into the same amount. So that was, and then on the flip side, we assumed that the program was free. On the cost sharing side, we assume that the average of kind of what's in the commercial market today. So again, some very high level assumptions were made on this, which could leave these costs conservative, but there's also, if this option wanted to be explored, we actually did this work for the state of Vermont many years ago when they were kind of looking at a potential all-payer model, and obviously a lot more detail would need to go into it. But we try to provide some kind of high-level estimates just to kind of get a gauge in terms of the dollars that the state would be looking at. So what would this mean from enrollment? Again, I think that the two key drivers of what would happen to enrollment is if you're expecting the consumers to actually contribute a premium. If there's no premium involved, you essentially, there are going to be some people that say, I don't want the coverage, even if it's free. But for the general assumption is that the vast majority of the current commercial and uninsured market would be enrolled. For the current premium scenario, we are assuming that people may not take up if they have to pay a premium for this. They may choose not to do it and to stay uninsured. So some significant difference in enrollment based on that. Another kind of overlaying assumption we made was that all employers would enroll or would kind of participate in this program, where when you kind of get self-funded plans, that may not always be the case. But again, if nothing else, that's conservative from the perspective of cost to the state. So then the overall costs of the state, as you can see, are very high in the $16 to $17 billion range in terms of total costs. But then in terms of, what the state could get offset that in terms of for the situation where you're saying that the consumers are going to, pay something into the contributions. You have the foregone premium tax credits to the extent that, the ACA market goes away in its current forms, and other potential offsets through waivers, et cetera, that could lower that cost. And then finally, we did make some assumptions around supply constraints based on some published articles, I believe specific to Maryland as well, that at least initially the Medicaid provider network, or just the network in Maryland altogether, may not be able to handle if all of a sudden all of the uninsured people had access to care. So we assumed some reduction in cost as a result to that. So in total, the net cost then to the state would be about $9 billion to $16 billion based on the various assumptions. And then the final slide I'll go through really quickly is just kind of the key finding or some additional considerations. So federal context, you all know probably better than we do. The federal policy is changing. Future years is uncertain. It's very possible we'll actually see something on the family glitch very soon. So that could kind of obviously change the cost and impact to the state for the various options. as we've talked about multiple times, the policy options impact different groups differently. So kind of depends on what the state's focus is. Availability and sustainability of state funds, working with other states. Sometimes it's like, okay, what funds do we have available? And then focus, what programs can we put in place to, kind of have the biggest bang for our buck when we're talking about improving affordability and accessibility to healthcare coverage. So, some of it may depend on what you want to do, and some of it may depend on what funds are actually available to do those things. Provider considerations, again, as I stated before, we're assuming the program or the provider network would stay in as is. If all of their payments end up going to Medicaid levels, we didn't model their participation or their financial solvency or what that might do. So I wanted to be very clear about that. And then on the federal waivers, the options, it's potentially that the options could be enhanced, where you could get some additional funds through waivers, and depending on how the options would be structured, it actually might be required for you to do a waiver. And then again, reinsurance, as we talked about, will have varying impacts on the program. So I went over my 20 minutes. I apologize, but
it's okay. It was necessary. So, it's not a problem. We're going to go on to the next person on the panel, Mr. Cohen. And we'll do all three panelists, and then afterwards for the commissioners and the members, I'll open it up for questions. Okay. Thank you for your patience. And we do appreciate you, Ms. Pepper. Next, Mr. Michael Cohen, please.
Oh, I'm actually just here to support Julie and answer questions. So we're ready for questions.
And Lydia as well.
Yeah.
Same.
They're my sidekicks. Yeah, they're the ones that actually did all the work, and I just get to talk about it.
Well, it's great to have sidekicks. So let's just get started with the questions. We're going to start with Delegate Resnick, followed by Lori Doyle, followed by Vinnie DeMarco. Delegate Resnick, good morning.
Good morning. Thank you, Madam Chair.
My pleasure.
And I agree. It's good to have sidekicks. They always make the hero look good.
I agree.
So,
and they're actually the heroes. I'm probably their sidekick, but yeah.
Julie, I have a scenario question for you on the Medicaid Buyin program. And this is not going to come as a surprise to most panelists here, but there has been a separate piece of legislation that I have sponsored that is similar to the Medicaid Buyin, but different in some key ways. And I wanted to get your initial perspective on cost to the state, given an adjustment to what you have analyzed. The suggestion has been a Medicaid buy-in, but instead of a buy-in, a mandatory requirement for all Marylanders to use, and paying for it through a payroll tax to employers, shifting the cost of employers paying private insurance to paying for the Medicaid program for all enrollees. It would clearly require an expansion of benefits from our existing program, which I suspect you're probably looking at as well. But in terms of cost to the state and the feasibility, what would be your initial reaction to not a buy-in, but a mandate that shifts costs to employers?
So would there still be a cost to, would the consumer still be paying a premium, or would it just be paid through tax?
It'll just be paid through a payroll tax,
okay.
Which I have estimated about 10% through previous analyses.
Yeah, so I think that goes back to kind of the estimate, and Michael, you can please add and correct since you did the vast majority of this modeling, but we're the one where there is no premium to consumers. So I think from that perspective, the enrollment would be probably almost everyone, right? I mean, I'm not sure if you can require it for self-funded plans, but maybe you can require it for residents to enroll in it. And so then it's just a matter of what the taxes are and do they cover it. So when we did the kind of analysis for the state of Vermont, when they were looking at something, they were also looking at kind of an employer tax, and that was kind of we didn't do the tax piece of it, but it was more about how it was going to be covered. Okay. So I think the costs would be very similar. I just think it's more about what the tax would need to be to raise those funds.
Mm-hmm. Actually, your estimate's about 9 million less than the estimate I got, but and I make an accommodation for ERISA plans that kind of gets around the federal requirement. But if I can, I will share with you that option and just get your thoughts on it offline if we can.
Yep, be more than happy to.
Sounds good. Thank you so much.
Thank you. Next, we have Lori Doyle, followed by Mr. DeMarco. Lori?
Thank you, Madam Chair.
My
and
pleasure.
Thank you, Ms. Pepper, for the presentation. Very interesting. My question may be too granular for what your analysis has done, but we in the behavioral health side of things are very interested in Medicaid buy-in because at least in the state of Maryland, the behavioral health benefits package in Medicaid is much more robust than in Medicare or commercial plans. And also, ironically, where I know there's concern about provider interest because Medicaid rates tend to be lower on the somatic side, the opposite is true on behavioral health side. So I was wondering if you've seen kind of how states are you seeing any sort of gravitation to these kinds of plans from people who have behavioral health concerns? Is one option better than another in terms of the ability to make the benefits package what you want it to be, or is it simply just a matter of cost? So I didn't know if you had any specific information from that angle. Thank you.
So we modeled, thank you for the question. We modeled the current essential health benefit package for the individual ACA market. So again, not the Medicaid benefit, but what's available in the commercial market. In terms of if any benefits wanted to be expanded, I'm not sure if you're talking about actual benefits or just the cost sharing. But for the benefit package, if you want to stick, the essential health benefits would have to be covered, but you could actually do some non-essential health benefits in the QHP option. If you're outside of the individual ACA market, you have a little bit more freedom, I think, to do some more unique things. But I don't know, Michael, if you want to add to that from a regulatory perspective.
Yeah, I think you hit it on the head. It is we try to align with the current benefit offering, so we didn't do anything more expansive than that. Beyond those, to do it, both in terms of the individual and small group market would have some costs, and then afterwards there are just kind of additional avenues depending on exactly what within the scope is wanting to be put forward.
Thank you.
We have next Mr. Benny DeMarco, followed by Dr. Rockwell.
Thank you, Madam Chair, and thank you, Delegate Kelly, for requesting this study, and Ms. Pepper and your team for the great study. On the targeted Medicaid buy-in one, could you compare that to Massachusetts direct subsidy program and maybe give us a little bit of what the difference would be to the state of going one route over the other? Any comparisons you might have between the two approaches?
I don't have a direct comparison off of that off the top of my head. It's something we could look into if that would be helpful. I don't know, Michael, if I don't want to put you on the spot, but if you sometimes remember some of the state specifics more better than I do.
Yeah, I know Massachusetts has a few different ones. I believe, and I could be misremembering and happy to follow up, is Massachusetts kind of direct subsidy program is not necessarily targeted to those that are ineligible for subsidies. I think it's just more general. And so I would have to think back exactly how the differences are, but I think it's one of the main differences is the target population. It's a question, is it something more holistic across the entire group to make things more affordable, or are you specifically targeting those individuals currently ineligible for APTC subsidies?
Yeah, and we have seen, for the record, a lot of states, especially with ARP, the American Rescue Plan, and the potential for subsidies continuing into the future and above the ACA, a lot of states actually, kind of shifting their focus to providing more subsidies to actually trying to provide subsidies to additional populations. So we are seeing a pattern in that in other states.
Thank you.
Dr. Rocker, and may I ask you, why is your hand different, the color?
I'm sorry?
The little hand is different, the
Well,
color.
you can choose colors on
Oh, wow.
on the hand. That's one of the options you can do.
Too fancy for me, but go ahead.
Okay. Well, thank you for allowing me to speak. I'm concerned about the network adequacy of a large increase in, large increase in numbers. Because, you know, the network is barely adequate as it is. You know, I was getting patients from Washington County coming down to me in Rockville for orthopedics because there's nobody between there and here to, you know, to take care of these people. And, you know, if you increase the number of recipients without increasing the payments to physicians, you're just not going to have enough of a group of physicians that are willing to take on this this challenge. So it's something you really have to consider. I know that, as you said, that there are Maryland's payments are better than most states, but still it's less than Medicare. And, you know, we're businessmen too. And so, you know, we have to pay our bills, you know, and you can't, you know, you can't do it on a shoestring. Okay.
Yeah, I understood and appreciate it. That's why we caveated. Yeah, I was outside of the scope to understand kind of the overall implications to the providers on this. But understood.
Thank you very much. Deputy Secretary Shu.
Thank you, Madam Chair. Nice
My
to be with all
pleasure.
of you today. I had a quick question about the numbers, Julie. On the Medicaid for All, you indicated we would get upwards of 210,000 uninsured people into the system at a cost of 15 or 16 billion, I think you said. And that would be like $75,000 per enrollee. So I assume I'm doing something wrong or not thinking about it the right way. Could you help me with that?
I can take I don't know, Michael, if you have an answer to that off the top of your head. If not, I can try to look at them.
Yeah, I think the state cost includes replacing subsidized people that already have coverage. So it's not just subsidies for those that are taking up new coverage, but it's kind of replacing current subsidies in the form of like those that get funding from their employer, for example.
So we would not only provide coverage for currently uninsured people, we'd also be moving currently insured people into the new system.
That's correct.
And the state would be picking up that cost.
That's how we modeled it. That's correct.
Yeah. So essentially, there would be no employer or individual market going forward. There'd be one big program for essentially everyone under the age of 65. Potentially Medicaid would be a little bit separate. And so, yeah, so going back to the earlier comment, yeah, the state would have to raise money for all of that. So,
and that, but would there be a parallel traditional Medicaid system to act so that we could access federal funds? Because presumably most of this incremental 210,000 is going to be non-federally subsidized. That's all state funds, right?
Yeah. So thank you. So that we excluded Medicaid out of the analysis, just assuming that right now Medicaid is paid through both state and federal funds. Somehow that would still continue, likely in the future. But whether you roll it up and you just get, you could roll it up into one program and then ask the feds to say, okay, give us that money as part of a waiver, and we'll use it to kind of help pay for the overall Medicaid for All program. Or you kind of keep it separate. We're assuming kind of the cost for that program would stay relatively the same, and there'd still be kind of similar federal and state costs. So there wouldn't be any additional state costs for that program, is our assumption.
Right. So you've modeled basically a Medicare, Medicaid only system, but it would be possible theoretically to have a Medicare, traditional Medicaid, and then a very similar to Medicaid, but not Medicaid, third system for everybody else.
Correct.
which would be a lot more obviously cost effective.
Than the current program.
Unless you get the waiver, you know, I guess unless you got a, yeah, okay, thank you, that, I appreciate that.
Thank you. I see Mr. Walters, your actual hand is on, so go ahead.
Yeah,
That works too here.
thank you. I couldn't find the raise hand button.
It's okay. We are flexible here. Go ahead.
Good. I wanted to follow. I have a couple different questions, but first let's stick with the doctors. Under this complete replacement program, then all doctor fees would become reduced then to Medicare or Medicaid fees. So that would mean there'd be no ability for doctors to bill higher in the private direct market that exists today. So I'm wondering what the effect would be on providers staying within the state of Maryland, because the point was raised earlier that doctors would get squeezed more in a sense in rates. So we'd have a major shift, and I worry about what would happen to our medical community if this didn't happen nationwide at the same time, because doctors could easily go across the state lines in Maryland to Pennsylvania, Virginia, or district, or Delaware, whatever, wherever. So did you consider that at all?
No, like I said, we didn't really, I mean, it was a very broad assumption we made. And I agree that that would need to be analyzed if this is something that the state would like to pursue. A couple of comments I'll make from similar work we did in Vermont was, while we definitely agree that from a revenue perspective for providers, this would definitely be a reduction. Some of the other pieces that were taken into account were uncompensated care. Theoretically, uncompensated care should go away if everybody's covered. That will impact providers very differently, though. And then the other one is administrative efficiency. So, right now where providers have multiple different, payment rate structures for different insurance companies, different lines of business, there would essentially be one payment rate for it may or maybe just be two, Medicare and the buy-in option. So so definitely some offsetting potentials, but it's definitely not to take away from the fact that it would be a revenue hit, and that would require additional analysis.
My next question on the family glitch: could Maryland just eliminate the family glitch in Maryland and the federal government if they don't do anything to fix the problem? Could Maryland just fix that problem by allowing subsidy equivalent, by looking not only at what the single contribution is for an employer, but also the family, and solve the glitch problem in a much simpler way? Did you look at that at all?
That was not part of the scope of work. I will defer to my policy expert to see if he has any information on that. But
yeah, so it kind of depends on the definition of fix. The state of Maryland could provide state subsidies to these individuals eligible through the exchange and fund it through state dollars. That's always possible. They couldn't make changes to the definition of affordability, and therefore the federal government pick up the tab for the advanced premium tax credit. So it like the change is possible, but the source of the funding under the current regulatory regime would have to be the state.
Okay, and one other thing, on one of your first pages, I think on page 5, your map of where everyone is now, it looked like the number of people in Maryland on Medicare seemed extremely low to me, because I think it said 3%, and that just surprised me if it's true.
It's just the under 65 population. That's why it's so low.
Oh, okay. I knew there had to be something that in my mind.
I did a double take on it too, so I know exactly. I had that one ready.
Okay, thank you very much. It was a good presentation.
Great questions. Thank you. Next, we have Mr. Deputy Secretary Shu. Your hand is still up. I would imagine that's probably you forgot to lower it, right? Yes. Thank you. So, Ms. Grayson, and then I have Delegate Collison.
Thank you so much, Madam Chair.
My pleasure.
Thank you to Julie and team. This is really interesting presentation. My question is just, of the 3 scenarios that you have modeled, have any other states done this? And if so, is there any data that we have to look at as the commission's reviewing these results?
So these were partly, I think, we did a similar analysis for the state of New Mexico. We did not model all of these options, but these were options that many of them that New Mexico looked at as well. We have also done kind of whether it's Medicaid buy-in, public option, different terminology and different kind of potential programs, have looked at it in multiple other states as well. But there hasn't been, outside of what Washington's implemented, and everything's kind of new still. So I think there's a lot of talk about it. There's not any real data yet, unfortunately.
Thank you.
Delegate Collison.
Thank you, Madam Chair, and Julie and team, thank you so much for this presentation. It's been very thorough. And I'm asking a question, not so much about your presentation, but maybe an adjunct to it. And Madam Chair and Senator Feldman, if this work's been done, let me know. But has there been any consideration of the impact of raising the Medicaid levels? So if we went as high as 600% FPL, so that we could capture at least some of this group, has there been any consideration of that and what the impact of the state would be moving forward? So it's a little bit different, not a little bit, a significantly different model, but I'm thinking that maybe with all the calculations you've done and looking at different configurations, you might have considered that.
We have not, but I think that is a good question. Just like with the reinsurance program, and every year the exchange looks at the attachment, right? To make sure it works. I think that's a good idea to do with Medicaid as well. So we should look into that. We should put it on the agenda, maybe send a letter from the commission to Medicaid to see if Tricia and the others can look at that. I think that's a good point. Okay. Very good point. So if I would ask our wonderful team if they can make a note of that, and if they can draft a letter for us to send, I think that would be a good idea.
Great, thank you.
My pleasure. Good point. I know that Delegate Ariana Kelly just wanted to see if you had any questions since this was your baby.
No, thank you so much. Actually, my questions, I kept popping on and off and raising my hand. I apologize. My questions were asked by the other brilliant folks on the panel. So.
Thank you so much. I really appreciate the presentation today. And it's been very thorough in the questions. I allowed them, whatever questions you had, because this has been, on our minds for many years. And we clearly need to do a lot more because there are different models. So thank you very much for your time today, Ms. Pepper. You and your wonderful teammates were amazing. Thank you.
Well, thank you so much. Thank you, Madam Chair.
Our pleasure. And next we have Michelle Everly from the Maryland Health Benefit Exchange, and she's going to give us a presentation on the easy enrollment. And this is a bill that this commission supported with Mr. DeMarcos and other advocates with their advocacy and leadership. So Michelle, good morning.
Well, and good morning.
Actually, good afternoon already.
Good morning to you in California. Good afternoon to those of us here. I want a little clarification because my expectation was that I was going to be doing presentation on the easy enrollment, but also on the 2 JCR reports that we submitted, one on the high deductible health plans and one on coverage options for the individuals ineligible for existing programs, the undocumented and the family glitch. So am I doing all 3 or just the one?
Why don't you go ahead and do all 3 while we have you here?
Okay, wonderful. My sidekick today is home with her brand new baby girl. So you get me solo, and hopefully we'll have Johanna back in February. So we're excited for her.
And I'm going to, Michelle, if I may, I'm going to give Senator Feldman will take over with you and the questions, okay?
Excellent, thank you.
Oh, okay. I'm in control. Go on.
You're in control. Thank
Always.
you. If we can go to the next slide, that would be great. So as I had mentioned, there's 3 areas that I want to go over today. The easy enrollment programs, the one that's in place and the one we're working on, the high deductible health plans, and the cover options for individuals ineligible for existing programs. Next slide, please. This is actually our second year of the tax filing for the tax filing easy enrollment program. So I'm going to start with that update. Next slide, please. You can see that the program continues to do really well, and we're learning as we go through this process. So what we can see from year over year, although we had a lower number of individuals who actually checked the box, there are more eligible, and nearly 900 consumers subsequently enrolled during the open enrollment period. So even though we may not have gotten them coverage right after their tax time, they came back and they filed for insurance at a later time. Let's go on to the next slide, please. One of the things we did different this year in 2021 is that we instituted direct outreach by our navigators. So we passed off about 15,000, over 15,000 calls. Of the 20,000 folks that we had, they completed the 15,477 calls. We had email campaigns, and we were able to be successful in getting additional enrollments. Now, what's interesting is that the customers, when we would speak to them, many would say that they didn't remember checking the box. They reported that they checked it by mistake, or they couldn't.
Carolyn, I think you've got, you might have to unmute yourself, or somebody will get back.
Yeah, I'm so sorry. I had to
okay.
switch devices. Sorry about that.
All good. Okay, Michelle, go on.
And so we also found that we had consumers that were enrolled in Medicare, they were undocumented or DACA recipients, or had an offer of employer-sponsored coverage. So the mere fact that they checked the box didn't convert them to an enrollment. We also heard from consumers that many of them had already completed the application and they had enrolled. That was terrific. And we found that if an application was in progress and we reached out to that consumer, it was much better for our conversion rate to actually get them enrolled. So we're going to continue this process as we move into the following years. And let's move to the next slide, please. This gives you a little bit of a glimpse of where we really saw our enrollments from 2020 to 2021. So again, many folks coming in were able to get assistance, financial assistance. We had some unassisted, and then of course, we continue to see many folks eligible for Medicaid and MCHIP programs. And that is always astounding to us, the number of folks that don't realize that there is free health insurance available. What's really terrific, again, if you look year over year, the unassisted and the Medicaid actually grew in population. So that was really good in terms of increasing those enrollments. Next slide. As we look towards future years, we are again drilling down into the data we have, and that's the best part of this program, is to actually know who's checking the box, where they are, where they live, what they're seeking. And so we're going to really drill down into that data and looking at geography, the household composition, income, age, race, and ethnicity. And we're going to look at where did they get hung up in the process? And was it when they were filling out an application, selecting a plan, enrolling in coverage? Where were they most likely to drop out in each step of the process? And what can we do to implement interventions to really increase the enrollment rates? Next slide, please. So that is it for the tax SEP. And again, a 2-year program, been very successful, even though the numbers don't seem astounding. they still are more people than we would have had enrolled absent the program. So that's been really good. Now we're moving into our tax filing, or not tax filing, but the Department of Labor phase 2. Let me restate that. The tax filing phase 2 and the Department of Labor implementation. We've got two things going on. Next slide, please. One of the original ideas that we had wanted to implement with a tax filing easy enrollment is that somebody could just automatically get enrolled. We've run into issues with being able to do that through CMS and through verification of citizenship and income and some other items. So we are looking at how we can get as much information from the controller's office and pre-populate applications and then really help those consumers to get enrolled. So we're still working through that process with the controller's office, but we are moving forward in terms of improving the program as best we can as we continue on. We've had real good success with the unemployment, working with the Labor Department in terms of creating the program for easy enrollment when someone files for unemployment insurance. So we began the process by being able to connect with their new Beacon system. As you know, they have a new system that's been successful. We've been able to get information to use today with our Medicaid program. And now we will be working towards, and hopefully by spring, we'll have everything in place for when someone comes in to file an unemployment claim, they can again check the box and we can get them health coverage. Next slide, please. That's all I have on the easy enrollment program. So if you want me to pause here, we can take questions, or I can continue on the
Yeah, I think let's split it up. You know, this is a unique, specific topic, and this Feldman Pena Melnick bill. You know, very proud of the commission and all the rest. I should add, and most of you may know this, but this is such a good idea. A bunch of other states are looking to do the same thing, and in fact, U.S. Senator Van Hollen is introducing a federal version of this in the United States Congress. He has a House sponsor from California, and just about 2 weeks ago, Senator Van Hollen announced that he's introducing a federal check-the-box easy enrollment version. So that said, why don't we go to Delegate Cullison, then I see Allison Taylor next. Delegate Cullison, you're up. You gotta unmute yourself. Bonnie.
Here we go.
Okay.
I guess one of the questions, thank you, Michelle, again, for your work. It's just tremendous. I saw that you saw that the greatest enrollments were in Montgomery County in Central Maryland. And I appreciate, I think the exchange does an extraordinary job of digging deep into data. But I guess I'm curious, as I suspect that on the Eastern Shore and Western Maryland, we've got higher percentages even of uninsured folks. Do you have any thoughts on why we're not seeing them coming into the program, or is that just part of the study that you're going to be doing?
I don't have anything specific now. Those are parts of the things we're going to look at and dig deeper. I mean, these are, folks coming in when they're filing their taxes. So we're not affecting it as much like with our outreach or marketing in targeted areas until we drill deeper into the data to find out exactly why you said, why is the tax filing more successful in one region than another?
Okay. Thank you. Thank you, Mr. Chair.
Hey, Allison Taylor.
Hey, Allison Taylor from Kaiser Permanente. Thanks for having me. Good to see you, Michelle. I had a question about your work with the comptroller's office. Do they have any kind of timeline for being able to assist with that, and maybe a recommendation that this commission could brief whoever the incoming comptroller is after the next election, since there'll be a change on the value of the program and that work?
I don't have solid timeline right now. We are working closely with them, and I think the meeting has been on a hiatus a little bit with Johanna out, but I believe it's ready to gear up back in February. So there's work ongoing, and of course we're continuing to do the tax preparation for next tax filing season. But the phase 2 of getting all the data needed to populate the application, I'm not sure of an exact date on that today.
Okay, thanks.
Okay, any other questions from members of the commission? I'm looking through. I do not see any. Okay, seeing none. Michelle, why don't we move to the next section of your presentation here, dealing with individuals ineligible for existing programs coverage options.
Great. So the 2021 Joint Chairman's Report on fiscal year 2020 state operating budget and capital budget had asked the exchange to review options for increasing affordable coverage to improve health equity for individuals who are ineligible to enroll in Medicaid and qualified health plans, and to make recommendations on options for health coverage and cost sharing. Specifically, the exchange was asked to report on costs, feasibility, and a review of activity in other states to serve this population. So that's what I want to review today, and I'll be going over today. And I'm hoping you all have a copy of that JCR report. Has that been shared? And if not, we'll make sure it gets shared. Jennifer, did the reports get shared as well, the JCR reports?
No, but
okay.
We certainly can.
Okay, good, because there's attached in those are, we had Lewis and Ellis and Hilltop do different actuarial studies. So that's some of the background data as well. All right, so let's talk about the ineligible populations. So undocumented immigrants, and what's important to note is that the undocumented immigrants are foreign-born individuals residing in the United States without authorization, including those who not only enter the country without authorization, but equally as important, those who enter the country lawfully and stayed after their visa or status expired. So that's one area we often forget. Someone may have come here on a work visa or a student visa, and then the visa expired and they remain. So we have to keep that population in mind as well. In that undocumented immigrants, we have 244,700 total in Maryland, and 115,900 are currently uninsured. We also have DACA recipients, and they are also ineligible for Medicaid and QHP, and we have 7,560 in Maryland. Now, the other category, which you heard a little bit about from Julie, is the family glitch. And these are individuals with family members whose employer offers affordable self-only coverage, but not affordable family coverage. And so that makes them ineligible for exchange subsidies because they can't get subsidies for the whole family because it is deemed that that coverage is affordable. We know this is a national problem, and as Julie indicated, are federal measures ongoing right now to change this family glitch, so everyone's well aware of it. We estimate in Maryland that there's 83,000 folks in Maryland that fall into this category, and 70 are uninsured. Next slide, please. In terms of eligible immigration statuses, generally Medicaid eligibility is limited to US citizens and lawfully present non-citizens. Many legal permanent residents must wait 5 years after achieving qualified status before they become eligible to enroll. Similarly, under federal regulations, only US citizens or lawfully present non-citizens are eligible to enroll in a QHP and receive premium tax credits. However, lawfully present immigrants with incomes below 100% of federal poverty level may receive subsidies if they are ineligible for Medicaid due to their immigration status. So we still have folks that, if they haven't reached that 5-year bar, they still can get coverage. And this would include lawfully present immigrants who, again, are in that 5-year bar waiting period. Let's move on to the next slide, please. So the federal regulations affecting coverage, individuals eligible for Medicaid, except for their immigration status, may be eligible for limited emergency services paid by Medicaid. Since 2002, states have had the option to provide prenatal care to women, regardless of immigration status. And states have also had the option to expand emergency Medicaid coverage through a Medicaid Disaster Relief State Plan amendment to include COVID-19 testing and treatment during the state public health emergency. In August of 2019, the Trump administration issued a final rule changing the public charge policy. So that rule in 2019 expanded the public charge rule, which made a lot more folks hesitant to come in and get health insurance, because health insurance or any public benefit could be deemed to make them a public charge and really help limit their ability to get citizenship. Now, the good news is that on March 15, 2021, Department of Human Services published a final rule withdrawing that public charge rule, or rather CMS, sorry about that. So 2020 Urban Institute survey of immigrant families living in the US with children under 19 found that nearly 30% of low-income immigrant families with children reported that they avoided one or more non-cash public benefits because of that public charge. So hopefully we're starting to see that trend reverse, and we're seeing that in our enrollments this year, which is a really good thing. All right, let's move into the next slide, please. So these are some of the current resources in Maryland that are available for folks that are not eligible. They cover, as we spoke about, the emergency Medicaid coverage, the Emergency Medical Treatment Act and Labor Act, and that requires Medicare participating hospitals with emergency departments to provide an appropriate medical screening, examination, and stabilization care without regard for the person's ability to pay. So therefore, many hospitals are legally required to provide that emergency care. Maryland law requires hospitals to provide free or reduced cost care as part of their financial assistance policies. And as you are aware, there was recent legislation passed that provides for payment methodology for being able to pay back some of those costs. Also, our federally qualified healthcare centers are community-based healthcare providers that provide primary care services in underserved areas. Generally, those FQHCs focus on providing services to vulnerable populations, and some focus on special populations, such as individual and families that are experiencing homelessness, migratory and seasonal agricultural workers, and residents of public housing. Next slide, please. Now, when we looked at different options in this study, what we came up with are 3 different options. And interestingly enough, again, these are 2 different firms that we're looking at doing the analysis, and I think we've kind of landed pretty similarly. So Section 30-32 waiver with state subsidy. California actually had submitted one of these in 2019, I believe, and ultimately they withdrew the request at the federal government level. So it was a change in the federal administration, and they didn't believe that it would go anywhere, so it was pulled. The several states have expanded their Medicaid and CHIP programs to cover narrowly targeted subpopulations of undocumented immigrants using state-only funds. So California, Connecticut, DC, Illinois, Massachusetts, New York, Oregon, and Washington they all provide coverage to children who meet income eligibility requirements regardless of immigration status. These state programs each set the state age requirements, income limits, premium amounts, and determine what the benefit levels will be. In recent years, states have explored various proposals to create health plans or public options to offer consumers an affordable alternative to existing fully private plans offered in the individual market. And Washington was one of the first states out of the gate on this. The public option has been, it was a slow uptake in Washington, although the intent behind that public option is to offer coverage that is lower in cost than existing individual market coverage and allow flexibility in offering coverage to ineligible individuals. As I said, in Washington, it was a slow uptick. It now is seeing a little more progress, but more to come on that. Next slide, please. So focusing and narrowing in specifically on the 1332 waiver with state subsidy, I want to talk a little bit about a high-level implementation considerations, potential implementation timeline, estimated cost, enrollment, and impact on the uninsured populations. So we'll go through that in terms of one, through the exchange and in conjunction with the state subsidy program, and two, specifically for undocumented individuals through a state-only Medicaid program. So these two options, however, are not mutually exclusive. For example, certain target populations could be offered coverage through a state-only Medicaid program, while the remainder of the ineligible population could be offered coverage through the exchange with a state subsidy. So how that would operate would be under a 1332 waiver, the exchange would pursue the ability to cover ineligible individuals. And as I said, this was something California had tried to do originally. Second to that would be able to not only provide coverage for undocumented or ineligible family glitch individuals, but also to provide subsidy for those programs. So for instance, the young adult subsidy program that we have today, because it's funded with state-only dollars, anyone could be eligible for that. So if we get that provision to allow ineligible folks to purchase through the exchange, they would also be eligible for that existing subsidy that's paid for with state dollars. Next slide, please. So it would have to be, when we're looking at the state subsidy program, some of the things we'd have to look at is whether we would want to do a tax credit or a simple subsidy. The administration of that, of course, it's something that the exchange is doing now. And when we looked at that, what we came down with is that the simple subsidy would really be easier to administer, less costly to administer, and really in line with what we're already doing today. So we'd also need to look at whether cost sharing subsidies would be administered through an advance payment, like we're doing today with the tax credits and a reconciliation process, or again, by allowing insurance carriers to build that into the silver plans, which is what we've done on the exchange. That the latter would again be an easier methodology because we already have that would be in place. When we looked at the timeline for implementing this, we assume it would take 3 years for the full enrollment to be achieved that we would like. Family glitch we see is pretty dependent on income. So lower incomes, we expect will have higher uptakes, and higher incomes, lower uptakes. But this is a very viable option to submit that waiver, allow undocumented and ineligible folks to get coverage, and then apply subsidy programs through them through our existing mechanisms. Next slide, please. These are some of the funding scenarios that were created by Lewis and Ellis. So the full population eligibility scenario is projected to result in enrollment of about 29,000 to 52,000 individuals in each year of the waiver, and is projected to reduce overall individual market premiums by 3.9% by 2028. And that is because of adding new, generally healthy entrants to the risk pool, again, in the individual marketplace, increasing the size of that pool and spreading those costs among more folks. The scenario would also reduce, we estimate, Maryland's uninsured rate by 6 percentage points, not percent, but percentage points, 0.6 to 5.4 from the current rate of 5%. Although, as you heard from Julie, that rate may be lower from the 2022 estimates that are still being reviewed. So this is the only scenario for which we modeled the impact on the uninsured rate. The others would cover fewer people and have a smaller effect on uninsured rates. Next slide, please. We then looked at if we limited this just to young adults, so not the full eligible, but just young adults. And again, this would be for folks under 35, and we looked at enrollment projections of 14 to 25,000 in that waiver period. So, and again, I failed to mention the costs. Actually, if we can go back one slide, I did not mention the costs, but if you have them in front of you, you can see the net cost to the state. This would assume pass-through funding from the federal government, so you can see what the cost of the state would be. Let's move on to the next slide. Again, just point out that next cost to the state. All right, let's go to scenario number 3. This is if it was limited just to incomes below 200%. And again, you can see where we estimate about 20 to 35,000 individuals each year, and to reduce the individual market premiums by 3.1%. Next slide, please. So then looking at moving off the 1332 waiver with subsidy program, we looked at the state-only Medicaid program considerations. And the state-only funds would need to be used because, again, federal funds cannot be used for ineligible folks unless it's or for non-emergency services for undocumented immigrants. And Medicaid is administered, as we know, through the MCOs. But the emergency assistance is administered through the fee-for-service program. So what we found, again, we looked at the full population, broad eligibility, targeted population, et cetera. And let's move on to the next slide. I think we've got some scenarios here. No, we only did the scenarios for the first. So you've got a lot of scenarios in that Medicaid program and cost. I think that Julie had just gone through. So then the third option that was looked at was the public option considerations. And you are, of course, have the Medicaid buy-in, the total cost of care, and the global budgeting model really precludes Maryland from seeing any savings in a public option reliant on rate setting like the state of Washington did. And that is, again, because we already have the rate setting, and many companies get their savings in hospital rate settings. We also figured in this study that the cost would probably be prohibitive for many low income folks if there's no subsidy on top of a public option. We know in the individual market right now with tax credits and with subsidy programs, many folks can get a health plan for less than $10 a month. And with a public option or a Medicaid buy-in option, we're not certain if that fee would be that low on a monthly basis. So let's move on to the next slide. That is it for this portion of the presentation, and we can stop and I can take questions before we move on to the high deductible health plan report.
Okay, thank you, Michelle. Okay, any questions on this second segment from Michelle Everly? Okay, I see Mr. Walters, you've got your hand up, but you're muted, so make sure you got to unmute yourself there. Okay, you're good.
Thank you. Michelle, I had one question. I wanted to get a clarification on something. on the glitch, this would have only, you believe it would only added about 7,500 people. So you're saying the balance of that 84,000 are already covered is dependence on the group plan, even though the cost range isn't there to,
That was what the Lewis and Ellis had estimated.
And also just curious, is looking at your study and the previous study before, do they both agree with about the same number of people that are in this glitch? Because your numbers were, I think, about 85,000, and I don't remember what their numbers were, but were they consistent between the two studies?
I would have to put them side by side. This is the first I've seen of the other study.
Yeah, and I don't have the ability to look at either one of them because I don't have either of them in hard copy. Thank you.
Okay. I see hand up from my great co-chair, Delegate Pena-Melnick. Your hand is up.
Thank you so much. I just want to say, Michelle, thank you. I know that you and I and a lot of advocates are working on a bill regarding the undocumented population. So we'll follow up with a call and a meeting. But thank you again. I just wanted to thank you publicly for being so flexible.
Okay, Allison Taylor, you're up next. Allison.
Hi, thanks, Senator Feldman. Quick question. Do you know why California withdrew their waiver?
Yes, so they had put it in and then the administration changed. And I think under the Trump administration, they didn't feel it was going to get any traction.
Got it.
Okay, any other questions before we go to the part 3 of the Michelle Everly presentation? Okay, Jocelyn, you still have your hand up. You're good? Okay.
I am good. It's a mistake. Let me figure out how to bring it down.
Okay. Okay. Well, thanks, Michelle. Let's go to the final phase, the high deductible health plan part of your presentation.
Okay, so this was another report that was that we had to do as part of the JCR reports. And what the intent was for let me just go back and read what I wrote here. So the Maryland Health Benefit Exchange, along with the Maryland Insurance Administration and the Office of the Attorney General Health Education Advocacy Unit, submit a report on high deductible health plans. And specifically, the request was that MHB provide data on the prevalence of high deductible health plans in the individual market for the period of 2016 through 2021 as available, the cost sharing requirements for those high deductible plans by service type, the number of complaints, and to get a sense of how people are utilizing healthcare services with these high deductible health plans. So that was that report. And again, we'll get all of these reports off to the committee. Next slide, please. So just to level set a little bit, here's some definitions of deductible. That's the amount a consumer pays out of pocket before the health plan pays. Preventive services are required now through the Affordable Care Act. There's services with no cost sharing. So those are things like immunizations, your well care visit, your mammogram, your colonoscopy. Those are the preventive services. Out-of-pocket maximum, that's the most that an enrollee will have to pay for in-network services covered within a year. And value plans. This is something unique to the exchange where we require carriers to offer a plan at each meta level of silver and gold value plans where there's a capped deductible. So we have on the gold, it's a capped deductible of 1,000, and at the silver, a capped deductible of 2,500. And this came out of work with the affordability work group, where we really continue to hear loud and clear from consumers, my deductible's too high, I can't use my health insurance. So really to respond to giving value benefits that consumers can afford and will use. And then high deductible health plans, which we're going to focus on here. Those are plans in that deductible portions is defined by the IRS. and they may or may not be paired with a tax-free health savings account that allows some pre-tax deductible coverage. Next slide, please. So for the IRS defined high deductible health plans, every year they come out with what the minimum annual deductible is, what's the maximum annual deductible, and other out-of-pocket expenses. On the chart here, you see what it was for 2021. The new rates coming out for 2022 are $8,700 for an individual for the out-of-pocket max, $17,400 for a family, and that's for the out-of-pocket maxes. So that's just where it was $1,700 and $1,400. So you can see it's obviously going up again next year. Next slide, please. There's lots of literature out there on the impact of high deductible health plans and the cost of high deductible health plans. Some of the literature that was looked at between Hilltop and Lewis and Ellis are the results are these several studies. So, and when I send this report out, you'll have all the links to all of these reports. But what they found was higher cost sharing is associated with lower care utilization. Lower utilization and savings are often due to the avoidance of necessary or preventive care, not price shopping. And there's a big, obviously, perception that deductibles that are too high are a barrier of care, and that folks avoid health care because of those deductibles. Next slide, please. This chart actually covers at 2016, 2019. We did not include 2020 in this chart because the utilization from that data was the first year of the pandemic, and it changed the existing findings a little. So that wasn't included for this presentation, and 20 and 21 data was not available. But what you can see from here is that the number of enrollees in high deductible and non-high deductible health plans remained on their plan for at least 320 days by age group. So that's really good. We always like to get folks to stay in their coverage, and that's what we call the stickiness of it. The non-high deductible enrollment was higher overall in each year, except 2019. And then what we started to see in 2019 was a little shift from non-high deductible to high deductible. And what we found was that the fluctuations are tied or can be traced to shifts in the carrier's plan offering. So for example, in 2019, and this is on exchange, the Care First family of companies increased the deductible in their gold plans from $1,000 to $1,750. So now that pushed them into the high deductible threshold, and that's what accounted for that large increase in that 2019. So it really does impact whether it's a high deductible offering or not. Next slide, please. This slide, I'm not going to spend a lot of time on, other than to say that you can see the shift between plans of whether it's, we call a base plan or a variant plan. Variant plans are if you change that plan at all to offer additional cost share reductions, et cetera. And again, what we can see is in 2019, there was a shift from most base gold plans being considered non-high deductible health plans to now being considered high deductible health plans. Next slide, please. Thank you. So when we talk about cost sharing, we looked at what the various types of services or cost sharing for various types of services are. The primary care, specialists, emergency room services, generic drugs, preferred brand drugs. And what we found was that there was really no clear pattern across service types and plan types. It really was a lot of variation based on the plan benefit design on what the plan was, what the coinsurance was, what the copays were. So that's where the carriers have really a lot of flexibility to make changes in what that cost sharing will be for those plans. Next slide, please. This next section is going to look at what we found with the utilization of high deductible plans versus non-high deductible plans. Next slide. What we found was that the per enrollee inpatient hospital admissions by high deductible health plan enrollees increased steadily but slowly from 2016 to 2019. The inpatient admissions by non-high deductible health plans enrolls at a similar rate before decreasing slightly in 2019. And the inpatient utilization was consistently higher for non-high deductible health plan enrollees. And this is all in the study that we had funded through Hilltop and Lewis and Ellis. Next slide, please. This slide talks to the outpatient hospital visits by high deductible health plan enrollees. And you can see that they were increasing steadily between 2016 and 2019, and then in a large increase in calendar year 2019 to more than double the 2016 rate. For non-high deductible enrollees, utilization per 1,000 of that outpatient hospital services was higher most years compared to high deductible health plan enrollees, but then it declined. So we just see the reversal of this difference in 2019 may require additional research to explain, but we think it's due in part to the shift of a significant number of enrollees from those non-deductible health plans to the high deductible health plans that I just spoke about. Next slide, please. When we looked at primary care provider visits per enrollee, what we found was that the PCP visits increase overall for high deductible and non-high deductible enrollees, with those in both plan types utilizing primary care services in a more similar rate by the end of the study period. And a 2015 analysis of the Commonwealth Fund found that a substantial portion of privately insured individuals were unaware that their plans were required to cover many preventive services without cost sharing. So that may have impacted it as well. Next slide, please. Both unavoidable and avoidable emergency department visits were higher on a per enrollee basis for non-high deductible health plan enrollees compared to high deductible health plan enrollees for each year except 2019. And that just, I don't have a reason for that other than, again, maybe that shift in the plans. Next slide, please. So finally, we also looked at, were there consumer complaints that were received, again, on this perceived notion that I have a high deductible health plan, I can't use my coverage, I'm not using my coverage, I'm not going to the doctor. And what we found was HEAU and MAA do not separately categorize the complaints specifically related to high deductible health plans. But what we found was that through the HEAU hotline and case handling insights, consumers reported that they chose their plans mostly on premium prices, which we know. They avoided routine medical care because of the out-of-pocket costs. We hear that a lot. And they use their high deductible health plan only for emergency situations. And they were afraid that there would be out-of-pocket costs, unexpected out-of-pocket costs, and that many are worried about how to pay a medical bill without any savings. And actually, there is studies that have been done that indicate that once you get, to $400, people really have a hard time figuring out how they're going to pay that $400 bill. So in conclusion, the research from this study demonstrates that high deductible health plans led to reduced utilization of necessary health services, and consumers found their deductibles to be too high and a barrier to care. The uncertainty over over benefits and low health literacy also leads to reduced care utilization. And actually, that's one of the focus area the exchange will start looking at, is how we can continue to increase health insurance literacy. And then utilization was consistently higher for non-high deductible enrollees than high deductible enrollees across several service types. And that included inpatient and outpatient, hospital admissions, primary care, and avoidable and unavoidable emergency department visits. So that was the result of that study, and I'm happy to take any questions.
Okay, well, thank you, Michelle. Outstanding presentation, all three parts of the presentation. Bob Atlas, you've got the floor.
Thank you, Mr. Chair, and thank you, Michelle, for the good work. Hope you'll get a break for your voice after this. But on the high deductible plans, I mean, this confirms what we've been concerned about for quite a while, which is that, you know, it's one thing to make sure people have an insurance card. At the same time, if that insurance card, you know, has huge gaps, especially at the first dollar, it's not very helpful. You know, as Michelle's findings underscore, you know, it provides a chilling effect on seeking necessary care, especially preventive care, even though some of these plans have you know, first dollar coverage for certain preventive services. Many of the enrollees don't understand that. And then there's the ones who don't realize that they have a big deductible. And so it's a combination of literacy, but it's also the weakness of the coverage itself that's problematic. And we had, you know, this is an inexorable trend. While Michelle's study was just on plans on the exchange, this is also true in employer-sponsored plans as well. And you know, we have to recognize that this is putting a burden on our population. It's one of the big drivers of medical debt. Frankly, it's not just people who are uninsured who are facing medical debt. And so, you know, we have to address this, and we can't hide out from these facts and fail to consider carefully how we truly protect people from cost exposure. Thank you.
Okay. Sure there was a question in there somewhere, Bob, that was without. Okay, any other questions for Michelle Everly? Okay, seeing none, I'm going to turn it back to you, Co-Chair Pena-Melnick. Before we do that, you know, I just, you know, and I think Delegate Pena-Melnick's going to have some closing thoughts and some remarks, but this would be an opportunity for anybody wants, for the greater good of the order here, you know, bring anything else up to the attention of the committee. I do know Mr. DeMarco did want to just bring to the attention of the commission, you know, a piece of legislation that's going to be introduced next session. So before I turn it formally back to Delegate Pena-Melnick, Vinny, if you want to just share all that with the commission members.
Thank you, Mr. Chairman, Madam Chairman, for another great meeting. And this commission has done a great job of recommending measures that have become law and help reduce the uninsured and move progress in Maryland healthcare. And next year, I want to make sure everyone on the commission knows Senator Katie Fry Hester in the Senate and delegates Robin Lewis and Brooke Learman in the House will put in a legislation to help small businesses afford healthcare. This is similar to legislation they introduced in 2020, which would provide significant funds to help small businesses through the SHOP program and other programs that the exchange has that provide small businesses healthcare. As you know, there was a program in 2007 that was enacted as part of the Working Families and Small Business Healthcare Act, which put in $15 million a year to help small businesses. That has not been in place since the ACA. The ACA program is much more limited. This bill would try to access about $45 million of federal money to put money into small business healthcare coverage and give the exchange $3 million to communicate to small businesses that that's there. So this legislation will be put in. I think there's going to be an op-ed in the Baltimore Sun right after the new year about it. And I would just encourage that some reference to this legislation be in the report, that it is a major healthcare proposal that will be before the legislature in 2022 session. Thank you very much.
Okay, with that, I'm going to turn it back to you, Delegate Pena-Melnick, to carry on the rest of the agenda, okay?
Thank you, Senator Feldman, and thank you all for a great meeting. So I just want to give a summary of what we have done and where we are, what is pending, and then open it up for discussion. And I want to thank Jennifer and Lisa for their work. So this is the summary of the commission work. Legislation in 2018 and 2019 tasked the commission with studying and making recommendations for individual and group health insurance market stability. To date, the commission has recommended tabling discussion on establishing a standardized benefit design or a basic health program for Maryland, or merging the individual and small group markets. Express support for the Maryland Health Benefit Exchange to pursue a young adult subsidy pilot program, which the Maryland Health Benefit Exchange has been reporting back on the impact and long-term cost. We defer making a recommendation on whether to adopt a state-based individual health insurance mandate until the Maryland Easy Enrollment Health Insurance Program Advisory Group submits a forthcoming report that it's actually due December 1st, 2022, next year. Recommended that the Maryland Health Benefit Exchange and the Maryland Department of Labor continue to work together to find a way to establish a means to connect unemployment insurance claimants with health insurance coverage options. Expressed continued support for the state reinsurance program and recommended the program be extended past 2023. So we done in a very humble way a great job at reducing the number of uninsured in the state of Maryland, at being creative, thinking outside the box, working with our partners. But we have a couple of outstanding issues. Last year, Jennifer gave a presentation to the commission on how other states fund their reinsurance programs. In our 2020 report, it was noted that a majority of commissioners supported extending the assessment at an amount sufficient to continue the current program. However, the commission stopped short of making a formal recommendation. And the commission requested additional information on pursuing a Medicaid Buyin program, and DLS contacted Wakely Consulting to do a high-level analysis, which was presented earlier today, and we had a really great discussion. So now I'm going to open it to discussion on the outstanding issues that I just discussed.
Madam Co-Chair, just
Yes.
one quick thought. Also, you mentioned that the commission has made recommendations and to lend support. I just want to, echo the fact that most all of those recommendations have actually resulted in legislation thereafter getting passed and enacted in state law. So it's one thing for commissions to put together reports. It's another thing for those reports to actually make their way through the General Assembly to the governor's desk. And so I want to, just make that point too. It's not just, producing reports and making recommendations to the General Assembly. So with that,
I agree with you. And if I can just add to show what this commission has done, before we created the health exchange, Maryland had actually almost 800,000 people, about 756,000 people that were uninsured. When we created the health exchange and we expanded Medicaid, because we were one of those states that immediately did it, we were able to reduce the number of uninsured by more than 50%. People, for the first time in all 24 jurisdictions, 23 counties in Baltimore City, had insurance. But then we realized that the people that were in the individual insurance market were people that did not get those subsidies, were not able to purchase insurance through their employer, and were paying a lot of money, and sometimes more than their mortgage. So what did we do? We decided, with the help of our partners in the Maryland Health Benefit Exchange and the guide of this commission, to go ahead and request and give permission for the exchange to request a 1332 waiver under the ACA to be able to seek a waiver, to do something different, to create a reinsurance program. So we did that, and we discussed the different attachment points and gave them flexibility to change those in the future. We worked with our partners and we negotiated and we actually compromised. And it has been a successful program where we had more than $1.2 billion to stabilize, which at that point back then, in 2 years ago, it was in February, it was about 218,000 people that were in the individual insurance market. So what did we learn? We learned, and Michelle gave an amazing report, that we have lower premiums for the last 3 years, a combined total of more than 30%. So it has worked beautifully. All right. So what have we learned now? We know that there's still people, about 300 and some thousand, that are mostly undocumented, that do not have insurance, right? We know that we have a special waiver. So we thought of the easy enrollment to be able to cover people and connect them to the exchange, and that is working beautifully. The subsidy for young people, that is working beautifully. So now, what's left is what we have at the table, whether or not we extend this program, because it actually comes to an end in 2023. So, we have to make some serious decisions. So that is where we are. I'm not going to even be humble about our work, because we have worked hard and have made a big difference. Okay. And that's because of the commissioners and our partners on this commission, and most importantly, our team, who are amazing and get us the best, people that are professionals and know what they're doing, and we follow their advice wisely. So now I am going to open it to people to give you 2 cents and let us know what you think about what is left at the table. First, we have Mr. Lee, followed by Delegate Collison.
Thank you, Madam Chair. So good seeing you again. Bless you all. Really glad to be on here once again. Absolutely. Pleasure's mine. I'm lending, just support to, of course, Vinnie DeMarco and the Maryland Citizens Health Initiative, which I'm a part of, Senate Bill 803. My name is Jamal Lee, and I'm a small business owner right in the Laurel, Maryland area. And, I got to tell you, we need help. We need help. If we're going to continue to grow and develop our organizations, we have to have good quality individuals in place. Those people warrant, good health care, plain and simple. And in order for us to do that, we're going to need help. Coming out of a pandemic, a major deficit, it was one of our toughest years ever. We're in the building stages of our company like we started from the beginning because of COVID. We thank God that we're, almost debt-free company, and it puts us in a place where we can continue to grow and develop. But it's very important that I think we focus in on what's paramount, and that's the workers, the employees, our communities, and their top priority to us. And it's important that we're able to attract high caliber individuals within our organization. We do that by having, high quality environment for them to create a good product here in Maryland, here in America. And what that comes down to is, these folks have to be, and my folks, I say my folks, we need to be healthy. Small business owners certainly are the backbone of, I believe, are the backbone of this economy. And we need to take every advantage possible to continue to grow and develop in a very difficult time. I know that $45 million is, for me, it's a lot of money. But $45 million is a drop in the bucket compared to what we really have to do to get back on track to help Marylanders to set an example for the rest of the United States of what's necessary to grow and develop. I strongly urge you to commit and build on this program and invest state funds to further subsidize health coverage for the small businesses. My colleagues, we really need this. We need that opportunity to continue to grow. I've watched so many of our folks go through major challenges, and it's almost it is heartbreaking to watch, folks fall by the wayside, and you do everything you can to help. But this right here is something that will definitely help, and everybody knows it. So hopefully you'll put your ballot forward and make sure that we get what we need as small business owners to continue to grow and develop our community. All right, thank you.
Thank you so much for giving us your perspective as a business owner in Maryland, and we really appreciate it. Delegate Collison.
Thank you very much, Madam Chair, Mr. Chairman. I want to thank you for your leadership on the commission and the work that's been done by this commission. I also want to support Mr. Lee's comments in terms of looking at the legislation that's going to be before us this session. But I want to speak a little bit to the overall context of the commission itself. I think what I saw today was just tremendous information. I mean, these are, well developed and analyzed studies of data that give us the information that I think we need to be making sure that we are using. If our ultimate goal is to make sure that every Marylander, and I mean every single Marylander, has access to healthcare, then we have to address the problems that we heard about today. And today the biggest problem we heard about today from my perspective was high deductible healthcare plans. I hear from my constituents all the time about how difficult it is because that they don't go to the doctor, or they may go for their preventive, but they can't follow up on stuff because they just don't have the money. I dealt with the hospital medical debt bill last year and realized just what a huge problem that is on both sides for the consumers, but also, for the hospitals. So I guess my request in terms of what's outstanding is, like, we heard at least 5 different sort of scenarios that we could think about in terms of making healthcare accessible to everyone today. And so, I'm hoping that, the commission, as it continues its work, is going to dig into these possibilities. And then in the short term, deal with things as we can. And I guess I would hope that we'd start to look really seriously at these high deductible plans. And is there anything that we can do, given the federal mandates around those plans, to begin to chip away at that? Just yesterday I was and this is probably part of a high deductible plan. The woman next to me was picking up her medicine and they said it was $1,300. And she said, I can't take it. And she walked away. I don't know what that medicine was for, but I know that she doesn't have it, and because she couldn't afford it. So, that's what we're trying, we're trying to save her and other people like her. And I appreciate the dedication and commitment, but I say, we've got information now, let's go forward and dig into it and come up with solutions as well as information. So thank you to the chairs for my chance to sort of pontificate here.
So I would ask, I appreciate your comments. They're very important. And one thing that I know we do with the information that is provided in this commission is that we, especially the legislators, go back and figure out with our partners, what legislation can we put in? I would advise you gently to work with Michelle Everly, which she's always amazing, to find out what possible legislation you can put in to address those high deductible plans. What can we work? What is being done in other states? What idea may she have that you can probably, draft a bill to address that, because I know a lot of the information that comes here, we take it, we read it, and then we come up with bills, and the session is starting next month. So the time is perfect to do that. And I agree with you that we need solutions. And I would ask Michelle Everly, not to put you on the spot, Michelle, if you could work with Delegate Collison on that particular issue, because I noticed that as well. That would be wonderful, because the information that we have here, everyone is free to even those at home, legislators, to use it and try to come up with some possible legislation. And I really would appreciate if you could work with Delegate Collison on this issue.
She's so difficult to work with. No, thank you for that recommendation, and I appreciate it, and I'll definitely reach out to Michelle on this.
I know I'm working with her on the other issue that I thought was really important today, which is the number of undocumented, right? That will go to our hospitals and affect our waiver, and they're not getting preventive care, and they're our neighbors. And I'm working with her on a bill that would address that issue. So I would recommend that everyone does the same as well, but those are excellent issues and points. I really appreciate it, Delegate Collison. Anyone else? Lori Doyle.
Thank you, Madam Chair. Just a quick plea. As we look at different options, different plans, different ways to go, that we keep in mind, because it tends to slip away, mental health and substance use disorder treatment. We have a big problem here in Maryland, and we're not alone, but we have to grapple with it. We have to change it. It's going to affect our total cost of care waiver potentially if we don't grasp it and deal with it. And so if we bake it into whatever we decide to do, will not only help with those issues, but the total overall cost of healthcare will be reduced. And the research is very clear. It's not just the cost of mental health or a substance use disorder going untreated on its own. It's the impact on somatic care costs. And so I just ask and plead that this committee continue to think about that moving forward when we're looking at options. Thank you.
Thank you for your comments. I really appreciate them. And you will be happy to know that I have been talking with Senator Augustine, which this is a very important issue for him, and Delegate Lorik Charkoudian, who are working on, different issues. And then, as you know, we have been having the committee meetings on this particular issue and the importance of it, especially with COVID. The rate of suicide, and I hope this is not a trigger to anyone at home or here, has been going up, especially with a lot of young people. Drug addiction has been going up as well. The numbers break your heart. So you're absolutely right. It needs to be in the front, not an afterthought. So I appreciate you.
Thank you. And thank you for your leadership and for so many, champions on this commission. Thank you so much.
Our pleasure.
Madam Co-Chair, before you go
Yes.
to the next raised hand. So I think I had mentioned it at exactly 2:00, I got to pop over into a Montgomery
Yes.
Senate delegation meeting. And so if I pop off, it's because of that. So I want to thank everybody ahead of time for a great year. Look forward to a great report. And I'll yield back to you because I see Kathy Grayson has her hand up. But
Thank you, Senator, and thank you for your work. I appreciate working with you. Kathy Grayson.
Thank you so much again, Madam Chair. I just wanted to say for the record, as you outline these open items and a ton of new content that I know everyone on the call is going to be digesting and thinking through, but didn't want the call to go to a conclusion without reiterating Care First support for the reinsurance program and just the essential need to continue that. As we know, it's been among the most successful in the country and really has been responsible for stabilizing that market. And if we don't renew it, I think we're going to have more problems than we'd like to revisit. So just wanted to put that on the record, and we're here to be a resource in any way as you all consider that next session.
Thank you so much. We really appreciate Care First partnership and work. as you know. So thank you for everything. So I don't see any other questions. So this is what I would ask our team to, as you're drafting the report. I think we did have an extended discussion on, and Kathy just referenced to it, on extending, the program past 2023. We know it's important. I think the report needs to reflect that, because otherwise it's going to affect everything that we're doing. I think that the stick here is whether it's an assessment, the way we're paying it, or how, what else can we do? And I think that we can leave that up to the committees to decide. But I think the report needs to definitely stress that we all agree, and we did, because we actually discussed this at a prior meeting, that it's important, and it's important to continue it. And it's just how we will pay for it that, the committees need to have hearings and make that decision. Am I right on that? Anyone that does not agree with that? Allison, your hand is up.
Sorry, I'm not saying that I don't agree. Just wanted to point out that there's still some uncertainty at the federal level about how much money is going to be available that could support something like reinsurance. So I think, however we proceed, needs to be a careful analysis of what's out there and, what the program should look like going forward.
And that's right. You said it in a different way from the way I said it, but absolutely. So I think, Jennifer and Lisa, is that clear enough for you for the report? I think that we learned a lot today about Medicaid, and I think the report should reflect some of those options and cost and points that were made as well. I think the report should reference to those high deductible issues that Delegate Collison discussed. In addition, I think it should reflect the points that were made regarding people that are left, the undocumented, community that are left as well. Anything else that the report should reflect that I have not referenced to? This is all of us here together. Will you be so kind and raise your hand so that I may call on you if I forgot something? Vinnie DeMarco.
I just, all that is great. I just love there to be a reference to the small business healthcare bill if possible.
I don't know how we can reference that because we have not taken a position on it, and it's a bill that came up for discussion. Maybe if there's a session about different issues or bills that was actually discussed, it can come up in that manner, but we really, it's a bill, we haven't discussed it. We haven't, so I don't feel comfortable putting that in there coming from the commission, but maybe the team can be creative and put it in there. Okay.
That would be great. Just a reference would be great. Thank you.
Yeah. Anyone else? Okay. Do you have any concerns or questions? Anything that we didn't discuss? Do you feel that you were not heard? Do you want to now, this is your time? Okay, wonderful. I don't see anyone. It is 2:03 your time. I want to take a minute to say thank you to Jennifer and Lisa for their organization, for getting in touch with the witnesses, for thinking about the different topics. We are very grateful for your time, and we really appreciate you. I want to thank the commissioners for your time. Every year we meet 4 times a year, and you're always here. And for not just being here, but for participating. I want to thank you for doing that because I know you're busy. I want to thank those of you at home that are watching us for your time and your efforts. And I want to wish you all an amazing, blessed, safe holiday. And I hope the year ends healthy for you, and I hope that the new year brings you many blessings, and stay healthy. Thank you so much for your friendship and your partnership. Take good care.